welcome all to our AP seminar. I know there's a series of alum webinar series for presentations this week, and we have one of our own, Dr. Mackenzie Fowler. She's an alum. She got her PhD in 2021. Then she went and did a postdoctoral fellowship in health services, outcomes, and effectiveness research. She came back to the department. She joined in 2023, and she also serves as an associate director for community outreach and engagement at the O'Neill Comprehensive Cancer Center. Her research focus is in cancer and aging, and she's going to talk about this very innovative, cool tool that she and her colleagues have developed, the Cancer InFocus. So with that, please join me in welcoming Dr. Mackenzie Fowler.
Quick correction, I'm the Director of Evaluation for COE, not the Associate Director. Probably won't catch me in that role for a long time, if ever. That's a lot. That's a lot. But anyway, thanks for coming. Thanks to Dr. Shrestha for allowing me to speak today. This is going to be a little bit of a different epi-seminar than what you're used to, because we're really talking about this tool that's been developed. I worked with the University of Kentucky to deploy this here at UAB. I cannot take all the credit. University of Kentucky did most of the legwork. I just helped bring it here to UAB and recoded the code to be UAB specific. I'm going to talk a little bit about some of the evidence of, what cancer looks like in Alabama and some of the social determinants of health. But for the most part, it's going to be kind of a live demonstration of the tool so that you can see what it can be useful for as far as public health practice, research, what have you. But to start off, my career, we reshared and everything's going awry. Okay, perfect. So just my career trajectory. So I'm a lifelong Blazer. I've done all of my training and education here at UAB. Several reasons for that. At every career transition, there was a reason for me to stay, but ultimately, the biggest thing is my research interest. So I'm particularly interested in older adults with cancer, understanding outcomes among older adults with cancer. They have different care needs compared to younger people with cancer. And the other thing is rural-urban disparities in outcomes among people with cancer. And so that's motivated by, you can see kind of, all of the training that I've done here, but you see down here some of the life events that kind of happened. So my grandfather was diagnosed with pancreatic cancer in 2014, and my grandmother was diagnosed with stomach cancer in 2018, right as I was kind of starting my MPH and then subsequently my PhD. And they lived in a very rural area of Alabama, and so some of the things that I saw them experience when it came to their cancer care really kind of started me thinking about, what does that look like as far as Alabama, as far as other rural people. And then coinciding with that, I got a job as a student assistant in the Division of Memory Disorders and Behavioral Neurology. And really started noticing that a lot of our patients that had dementia and Alzheimer's were kind of experiencing similar things to the patient, or my grandfather as a pancreatic cancer patient. Not necessarily, the cognitive decline wasn't the same. My grandfather didn't have a lot of cognitive decline, but just some of the care needs and, concerns surrounding both of their conditions as an older adult. It kind of got me pondering what that overlap looked like. And so as I started my PhD, I became a graduate research assistant with Dr. Richard Kennedy in the Division of Gerontology, Geriatrics, and Palliative Care. And learned a lot more about geriatrics under his mentorship. And then as a postdoc, I worked with a geriatric oncologist. So he's dual trained, double board certified in geriatrics and oncology. And so through that, got more of the cancer training and then moved back over here as an assistant professor. But if I had to tell the students in the room, a couple of things, the first thing I'd say is just find what fuels you. Find the reason to get up in the morning, do the work. For me, that's my grandparents. For me, that's thinking about what they went through and not wanting my parents, myself, my siblings, anybody else's family to go through those similar hardships when it came to receiving cancer care. in Alabama. And fortunately, my grandparents were, better off than a lot of people. But, that just makes it even more of a motivator, thinking about the people that aren't as well off as they were. The second thing I would say is network. I'm kind of a shy person, like just doing this makes me a little nervous, but the biggest thing that's gotten me to here is meeting people. Being mentored by good people, being introduced to people through those mentors, and fostering those relationships on my own. So if you see somebody at a conference and you know their work, just walk up and introduce yourself. It won't kill you. It hasn't killed me yet. Even though I have to go back to my hotel room and lay in the dark, it won't kill you, and it will actually benefit you. So, even if you're staying at the same institution, networking really benefits you, because I've gotten to know a lot of people across the university in various disciplines, and then of course gotten to know people nationally. So any questions about that before we move on into kind of the actual talk? Okay. So, like I said, I'm not going to dive too deep into research or anything like this. This is really mostly about this epidemiologic type tool. But I do want to orient everybody to why it was kind of important to bring this to Alabama. So first off, this is the most recent data that we have. Don't ask me why incidence and mortality are in different date ranges. I don't know. But for 2018 to 2022, Alabama was actually 38th highest in the nation for cancer incidence. And we have a lower incidence rate than the national average. And you're probably sitting there thinking, really? Yes, we do. However, we're 11th highest when it comes to cancer mortality, and we are higher than the national average by, I think the national average is 145 per 100,000. So we're about 18.8 per 100,000 higher when it comes to mortality. So what does that tell us? It tells us that things that are affecting mortality are probably more salient in Alabama than things that are affecting incidence. So social factors. Racial disparities, rural-urban disparities, things of that nature. Even screening. You might think of screening when it comes to incidence because it's helping diagnose cancer, but really screening is secondary prevention. So that's looking for disease that's there, but it hasn't manifested symptoms yet. So they're already an incident case. You just don't know it until you screen them. But if you get screened too late, then that increases your risk for mortality. So even things like screening, and ability to access screening are going to be what's affecting cancer mortality in our state. And we'll get into a little bit more as we get into the tool and the social determinants and things of that nature. The leading causes of cancer incidence, they're what you would expect. They're the leading causes of cancer incidence pretty much nationwide. Breast, prostate, lung, colorectal. Now I do want to add melanoma in there. And melanoma is not in the top 5 for the nation, but it is here in Alabama. And I would expect it's probably we have a lot of farming in our state. We have a lot of people who work outside. Maybe they don't protect their skin. My dad is guilty of not protecting his skin, even though he works outside. So that's probably why melanoma is fairly high here in our state. The leading causes of cancer mortality, similar, but notice there's some switch around there. So breast is the leading cause of incidence, but only the 3rd leading cause of mortality. Again, some of this is because of how treatable the disease is. So lung cancer is extremely aggressive. Even if you catch it early, the treatments are not very good. Whereas breast cancer, if it's hormone positive, you're probably going to do all right if you catch it pretty early. Even if you catch it stage 3, with the hormone therapies that they have for breast cancer, it's pretty survivable. Survival rate for breast cancer overall is 96%. The other thing that you see there is pancreatic cancer, which of course is what my grandfather had. It is the 5th leading cause of death here in Alabama. And it's in the top 10 of cancer incidents, but it's number 9 or something like that. Again, very aggressive cancer, one that does not have a screening test, one that does not have treatment, so that's kind of why it's elevated. The rest of these, though, these all have screening, and so that's kind of where this social determinants framework kind of comes into play. For something like pancreatic cancer, it doesn't matter if you're black, white, green, blue, or orange. It doesn't matter if you're poor, rich, middle class. It doesn't matter if you are employed or not. Pancreatic cancer is going to get you. And I hate to say it like that, but it's just the truth. It's extremely aggressive and extremely hard to deal with. So it doesn't really matter what these social factors are. But if we look at the social factors when it comes to leading causes of incidence, we can also decrease some of these leading causes of mortality as well. As far as trends over time, we really, in Alabama, over the past 23 or so years, I hope that's okay to see, not really much change. We see 2020, there was a dip there. We all know what happened in 2020. Not a whole lot of people getting screened, not a whole lot of people going to the doctor because we couldn't. And everybody was so focused on just handling COVID. So the incidence decreased because we just weren't detecting cases. But then when we look at the death rates over time, we see kind of a steady decline. This is pretty consistent across the nation. We've seen a decline, but I want to note that we are still higher than the national average, even though mortality has declined over time. This looks different for different populations. Black individuals have had a slower decline over time. There's still a major gap between black and white mortality when it comes to cancer. It also depends on the cancer type. Mortality from breast cancer has significantly decreased over the past 20 or so years. So, it depends on what you're looking at, but I just kind of wanted to give an overview that it has declined, but it's still a problem here in Alabama. So that brings us to social determinants of health. And I think everybody's probably familiar with social determinants of health, but I want to just orient you to the definition that I use, which is from the NIH-wide Social Determinants of Health Research Coordinating Committee. So that they state that social determinants of health are the conditions in which people are born, grow, learn, work, play, live, and age, and the wider set of structural factors that shape conditions of daily life. So this could be a host of things. This could be social factors, economic factors, legal factors, system level, like the healthcare system, policies, anything that determines our opportunity to get jobs, education, housing, transportation, access to things like green spaces in our neighborhoods, even access to internet, food, healthcare, even our social environment as far as the people we just like hang out with, and then any other conditions of daily life. But I want to just emphasize that social determinants, if you just talk about them, they're inherently neutral concepts. So they don't necessarily have to be bad. I think a lot of times we say social determinants of health and people immediately go to, that's bad. But I have a social determinant of health, you have a social determinant of health. So like I have an education level, you have an education level, I have an income level, you have an income level. We all have our social determinants of health. Whether those are adverse, neutral, or health promoting when it comes to our health outcomes depends on like what level they're at. So typically we think of people who are, under the poverty line as maybe people who are at risk for worse health outcomes, but then people who are over the poverty line are, doing better when it comes to their health. So it just depends on what level you're at. The other thing I want to emphasize is that these can be measured as us as individuals, my education level, my occupation, my insurance status, or they can be measured at the area level. So the area that we live in. What is the access we have to food in the neighborhood that we live in? What's the average poverty level in the neighborhood that we live in? And you can imagine that those things really differ across states, across counties. The best example I can give is Jefferson County. We've got Inslee on the west side, and then we've got Mountain Brook kind of southeast of us right here. And those are two very different places. People in Mountain Brook, very well off, very well educated, have access to whatever they need whenever they need it. People in Inslee, not so much. They don't have a lot of infrastructure in their area. There's a lot of crime in that area. A lot of people who, are not doing well economically. And so you can have very different places in the same county. And so that's, again, another reason why we're bringing this here to the state of Alabama. So to make this, even further, Alabama, we have a high rate of adverse social determinants of health, particularly in the Black Belt region here, which I have highlighted. Of course, I think most people are familiar with the Black Belt. We'll see this pattern as we look in the tool and when it comes to cancer outcomes. If you don't know, the Black Belt is primarily a black population. That's not why it's called that. It's called that because of the black soil, which was very fertile for farming. Of course, though, that is where a lot of black individuals settled when they were brought here in slavery. And so while there was a migration of black individuals up north after the Emancipation Proclamation, there remained a lot of black individuals here in Alabama that continued to settle in this part of the state. So yes, there is a large black population there, but it is named that because of the soil. But they still have a lot of adverse social determinants of health. So about 42% of our population lives in a rural area. 15% live below the 200% federal poverty line. 16% of households are food insecure, so they don't have good access to healthy foods. And our average social vulnerability index across the whole state is 0.5. And so if you don't know what social vulnerability index is, it's a measure from CDC, basically developed to determine how a neighborhood would react if there was a disaster. So that could be a natural disaster like a hurricane or a tornado, or it could be, a pandemic. So it ranges from 0 to 1. So our overall average SVI is 0.5 in Alabama. So we're kind of like in the middle. If a disaster happened in Alabama, it was kind of a coin toss of whether we're going to do all right or not. But this varies dramatically across counties. So again, we'll look at this in further detail in just a little bit. As far as it relates to cancer outcomes, the social determinants of health can affect the entire cancer continuum. I don't know if that's easy to see or not. This is from NCI. This is the cancer control continuum. It spans from etiology all the way to survivorship. Etiology being things like, what's causing cancer. It can be environmental factors, genetics. Of course, genetics, we can't change that. Prevention, so tobacco control, diet, things like that. So you can see how social determinants would impact a variety of these things. So environment, what environment we live in, that could affect the etiology of cancer. If we have access to healthy foods, that could affect our ability to prevent cancer, so on and so forth. And so just some broad, like literally 1,000-foot aerial overview of some of the things. These are more of the things that I research, but just some of the things that have been identified when it comes to cancer. Areas in persistent poverty have higher cancer mortality rates than those not in persistent poverty. So persistent poverty is an area that at least 20% of the population has lived below the federal poverty line for at least the past 30 years. So since 1990, as of the 2020 decennial census. So since 1990, these areas have been with a significant amount of their population in poverty. Matter of fact, they've looked at persistent versus current poverty areas, so areas that have been in persistent poverty versus areas that are in current poverty. Those in current poverty still doing worse than people that aren't, or areas that aren't in poverty, but the persistent poverty areas are doing way worse than them. So it's kind of this dose response effect sort of poverty. Rural areas have higher incidence and or higher mortality rates for many common cancers. This kind of changes based on the cancer a little bit. So I'm not going to get into too much detail here, but I can tell you, like for colorectal cancer, incidence there's not like that much difference when it comes to colorectal cancer. Maybe I'm mixing it up, might be breast. Anyway, but definitely for colorectal cancer, there is a higher mortality rate. You can think about that as maybe people aren't getting screened as readily because colonoscopy is a big barrier for a lot of people because it takes 2 days. You got to do your prep and then you got to go and get your colonoscopy. So for people living in rural areas who maybe don't have access to a hospital, that might be a 3 or 4 day affair, or maybe they just don't have a job that they can take off work for 2 days and go and get a colonoscopy. So they tend to get diagnosed later and end up having higher mortality rates. Living in a food desert increases your risk for obesity-related cancer mortality. I think we can all kind of see how that would work. If you're living in a food desert, you probably are eating a lot of processed foods, a lot of things from convenience stores, etc., developing obesity, and as a result, getting obesity-related cancers, which then, kill you. And then finally, increasing neighborhood deprivation is associated with higher cancer-related mortality rates. So this was a really interesting study from American Journal of Epidemiology. It looked at neighborhood deprivation over time. And for areas where neighborhood deprivation increased, so did cancer mortality. And the opposite was true for areas where neighborhood deprivation decreased, cancer mortality also decreased. So we see that these social factors are driving our cancer-related mortality in some way. Now, of course, there's a lot of kind of interaction between your individual and your area level, and that's an extremely hard thing to tease out that a methodologist might be better suited to talk about than me. But the point is, these are really important when it comes to studying cancer outcomes. So that brings us to kind of what the role is of the NCI designated comprehensive cancer center. So UAB, our O'Neill Cancer Center, is the only NCI designated comprehensive cancer center in Alabama, Mississippi, Arkansas, and Louisiana. We were one of the first comprehensive cancer centers established from the National Cancer Act of 1971 that was signed by Richard Nixon. There's 57 total in the United States, UAB of course being one of them. And the goal of these centers is to really be a leader when it comes to research, care, prevention, screening, the entire gamut of cancer, and to be responsive to their catchment area. So our catchment area is the entire state of Alabama. So that's how we led into this this tool here, was to be able to better look at our catchment area of Alabama. So Cancer InFocus, Alabama, we developed this in conjunction with our friends at Markey Cancer Center at the University of Kentucky. They are a newly designated NCI Comprehensive Cancer Center as of, I think, 2023. And so Dr. Burris there, the first author on that paper, I met him at a conference, and he told me about this tool that he developed at Kentucky. And he said, you know, we could bring it to UAB because we are prepared to license it out to other cancer centers. And I said, okay, let's look at it. And so it's really just a data gathering and visualization platform. And it's split up by different catchment areas for different cancer centers. So I, of course, did UAB's. It's Alabama, the whole state, and it really gathers data from across various different publicly available data sources. So you're not having to go to Census website and CDC website and this and that and the other and pull all of these data sources together. They're already gathered there for you, and they're able to be mapped across the entire state. It's based on an R-run platform. It's a Shiny app, if you're familiar with R and Shiny apps, but that's what it's based on. And so the way we access this, and I want to pause for a second. We are trying to update this with new cancers that they've gotten, new data that have come out. When we first built this, there were no issues. Now information security has blocked the pull to the data page. Thought it was only HSIS side, so I was going to talk to Dean Irwin after this talk about getting it hosted on School of Public Health. Now it's not working on my computer either on the university side. So we're going to have to figure that out. Apparently it's an issue with the SSL license for the site that the data comes from. So I may have to talk to Todd at the conference next week and tell him that we're going to have to figure something out. But anyway, so stay tuned. It will get updated eventually if I don't cry first because of information security. But it is on our O'Neill Cancer Center website. If you go to the Community Outreach and Engagement tab, and there's a link here. I don't mind sending these slides out if anybody wants them. And then you'll go to Cancer InFocus, Alabama, and we'll do, like I said, a live demonstration here in just a second. This is the first thing that's going to pull up. This is the main dashboard. And so you can see the main dashboard is really just kind of an overview of each county in the state, what it looks like. It defaults to sociodemographics and the total population. So you can see the distribution of the total population across the state of Alabama. Gives you an automatic scale here and tells you the data source up here. So you can see that most of our population lives right here in Jefferson County. I know everybody's shocked, right? Madison is quickly gaining on us, though. So anyway, and then once you'll see this in the demonstration, you can hover over these counties and it'll tell you the value for each county. But there's 4 dashboards in total. There's Cancer InFocus, that's that main one where it just gives you the distribution. There's Cancer InFocus profiles. So if you wanted to look at a specific county in Alabama, Bullock County, you could pull the data profile there for Bullock County. Cancer InFocus bivariate, which is my favorite because it allows you to overlay 2 different variables. So for example, if I wanted to look at cancer mortality and food insecurity, I could overlay those two variables and it would give me kind of a chloropleth type map-ish, kind of showing where is cancer mortality high and food insecurity high. And so we could see those areas that have kind of both. And then there's Cancer InFocus hotspots, which allows you to look at hotspots and cold spots of any variable that we have in the platform. So there's different categories of variables. There's county level and then there's census tract level. So largely most variables are available across both levels. So census tracts being a smaller subdivision of the county, so more akin to a neighborhood. The only thing is, if you're wanting to look at cancer incidence and mortality, those are only available at the county level. They won't let us publish rates below the county level for risk of re-identification of patients. So you're only able to get those at the county level. We also have overlays. So you can overlay county boundaries, where food deserts are, interstates and highways. Here in Alabama, I mean, that's 459, 2059, and 65, so not a whole lot of interestingness there. You can also overlay where federally qualified health centers are, where other health professional service areas are. The entire state's a health professional service area, so I don't know that that's very helpful in Alabama. Were you asking a question?
Yeah, I want to ask a question.
Yeah.
I don't know if you read this, but apparently the closer you are located within 2-mile radius of a golf course, higher incidence of cancer. I was wondering if you could add.
We could probably add golf courses. Yeah, so that's the other thing. So we are, in addition to trying to update with the new cancers and the new data that have come out from census and everything, we are working to make this more Alabama specific. So Dory Peckmezzi in Health Behavior, she did her DIAL project a few years ago, and they did like an environmental scan or I don't exactly know what it's called, where they went across Alabama and identified where all the parks and green spaces and things were. And so Dr. Shire Brown in Health Behavior was like, can we add this to Cancer InFocus? And I was like, yeah. After I talked to Todd, made sure. But yeah, he was like, we can add anything y'all want to make it specific to Alabama. So we could probably add golf courses too.
Golf courses, farms, up until 1989, Alabama allowed toxic waste being disposed in fields.
I'm not shocked by that.
Yeah. So the closer you were located to a farm or a large field, more likely you would have all kinds of.
Well, that's interesting because we have the Robert Trent Jones Golf Trail here in Alabama, so we've got a lot of golf courses. But anyway, so you can see all of these things that we can add, the geographic overlay. So where are mammography sites available? Where are oncologists? I don't think we have any Superfund sites in Alabama, but we do have a lot of toxic release inventory. Oh, we do? Really? It's not showing up on the map, so I'll double check that. So anyway, as far as before we get to the live demo, I just want to talk about what we can use this for. So I want to emphasize this is not the end all be all in data tools, okay? This is simply a tool. We can use this to disseminate information to researchers and public health practitioners so that they can develop research questions, they can develop strategic plans, they can develop public health interventions responding to the needs of a particular area in our state. We can determine where targeted interventions should occur. I've used it for a grant application just to demonstrate, okay, this is where colorectal cancer is highest in Alabama, Clark County. If you didn't know, Clark County has the highest mortality rate overall in Alabama. Their hospital closed. And program planning, surveillance, you know, if we look at this over time, our community partners in the Office of Community Outreach and Engagement, the Forge Breast Cancer Survivorship Center up the highway or up the road here up 19th Street, they have used this heavily to go into specific census tracts and specific neighborhoods in Alabama to tell women with breast cancer what their services are, because they provide financial assistance and a host of services for women with breast cancer. And so they've really used this heavily. So we're really trying to disseminate it and really get it out there for our community-based organizations, our public health partners, and our researchers, of course, to be able to, you know, just think and target our state particularly in particular areas of our state. So we will go now. Let's see if I can make this work. Oh, I do not like this angle. of my face. Okay. So let me pull this and then go back to Zoom and hit share. Okay. So again, to get here, we're good. I just Googled O'Neill Cancer Center and clicked on the link, go to Community Outreach and Engagement, Cancer in Focus, Alabama. So it takes a second, and at least it's still running, at least now that it's deployed, information security hasn't blocked it, but trying to update it, they have. Headaches. Extreme headaches. But so like I said, it defaults here to sociodemographics and total population. Really the kind of crux of it is you can toggle between county and census tracts. So if we look at the census tracts, this for total population gets a little bit difficult, right? Because it's harder to see and the scale is a lot larger. But for other things, it might be a little easier. So I'll go back to county for a second and we'll look at, So we're going to select our category of variable. So if I'm wanting to look at cancer mortality, you can see, so this is Clark County, like I said, highest cancer mortality in the entire state. This is for all races, all sexes. And again, it gives you the scale here. But you can also toggle different race ethnicities, different sexes, and different cancer sites. So we do have some new cancer sites. Like I said, we're trying to update things like myeloma. I do want to point out that as you toggle this even further, so let's go to cervical cancer. So you see that there's some grayed out areas. That's where data is not large. There weren't enough cases to be able to report that without the risk of re-identification. And then, if you toggle by race, of course, that's going to get even smaller, right? But for some cancers that are more common, so cervical cancers, I know we hear a lot about cervical cancer. It's actually not as incident across the state. But if we look, say, at female breast cancer, that gets a little bit better, especially for white women. But this is one thing I want to point out. This is the black belt. So the cases aren't high enough. When you toggle for white women, there's not enough white women living in the black belt that are getting cancer to display it. Yes.
Mackenzie, can you change the time so that you can look at multiple years at once in order to try to get around this problem?
No. So this is just pulling from the state cancer profiles data, and that's from NCI, and so that pulls for 1 year or one time frame. So when they release new data, it'll update to 2019 to 2023 for incident or mortality. Sorry, whatever we're looking at. Now I think the easiest thing would be to download these maps and have them over time and see where things are changing. I think that's probably the easiest way to do surveillance with this. That's an interesting point, though, and I would be willing to bet Todd's probably thought about that because all of the data are actually archived on their website, so you probably could add as more data come out. I think it's only been really working for about the past 2 years, so you're probably going to have about 2 time periods with this already archived, so 2017 to 2021, 2018 to 2022, and then maybe this upcoming year. So to see a longer pattern, it's going to take a little while, but you probably could add that within the code there. So I'll add that to my list of things to talk to him about. But the point is, there is some data suppression when it comes to cancer mortality, cancer incidence. Incidence is probably a little bit better because there's more cases of incidence than there are mortality, right? More people die or more people have a case than, black incidence looks better, right? The other thing, though, you can add all these different geographies. So this is where food deserts are. You see a big one right here. That is Pickens County. You also see that the incidence is really high. So anyway, and then of course, like I said, you can you can add where mammography services are. So you can see, where all the mammogram services are, and then there's none right here. So all of these women, Marengo County, they got to go down to Clark County. I bet this has changed because, no, these are still open. But Thomasville Hospital, which was one of their biggest hospitals, they closed. Anyway, you can play around with it. I'm not going to belabor it, but I just kind of want to show y'all how this works. So then if you go up here to other dashboards, you can go to Cancer InFocus profiles. So again, if we wanted to Jackson County, so that's Jackson County, this is Scottsboro is the main city there. You can download the data set, you can create a data profile, so it'll download this data profile for Jackson County specifically. You can also go to data table and it will tell you the value for everything that we have in the platform for Jackson County, as well as the catchment median, which for our case is going to be the entire state. So you're comparing Jackson County to the rest of the state. Again, it has every single variable that you could pull from our platform. You can also go to bar graphs up here at the top for the profile. Okay. And you can select different variables. So if you look at cancer incidence, all cancer sites, it's going to plot this little bar graph, and it's going to show you where the county that you're interested in stands when it comes to cancer incidence, and then it's going to have all the rest of the counties here, compare it to the catchment median. So Jackson County has a little bit higher cancer incidence than the median in in Alabama. So you can do that with any of these variables. Black population living below poverty here. Jackson County, kind of middle of the road. Highest is going to be DeKalb County, which is interesting. So anyway, any variable, it'll create a profile. You can look at all of the bar graphs you want to, anything like that. Bivariate, like I said, this is my favorite. So you again can toggle between county and census tract. But then you can select, say, your X variable. So let's say we want to look at cancer mortality across all cancer sites. Let's see, social vulnerability index. So what it's going to do is it's going to give you this scale here, low to high. So the darker blue is higher cancer mortality as the X variable. Darker red is going to be higher social vulnerability index, so the neighborhood or the county's higher in social vulnerability. And then, of course, this dark purple is where they're both really high. And it kind of gives you this scale here. So Clark County, high mortality, high social vulnerability. And again, you're kind of seeing this pattern here, this black belt pattern here. That's where a lot of this darker red is happening. So it's kind of interesting just to and then again, you can overlay these geographies, right? So here's the oncologist. Look where there's none. Yes?
So I have a question, just comparing the visualization between the NCI tool and this as well. What is the difference? Does this give you more high-level Alabama specific information, or is it that you're just pulling from NCI and focusing on just Alabama?
So if you're talking about, are you talking about state cancer profiles from NCI?
Actually,
Yeah. So they give you a map as well. They have a limited number of variables there. So I think they have demographics and maybe some social determinants of health. This platform has a whole lot more. So, I mean, there's really probably not that much difference. This bivariate dashboard is different because you can overlay those two variables. You cannot do that with state cancer profiles. It's just giving you the distribution. So there are some differences. Like I said, we have a ton more variables as far as environmental variables. I don't think that state cancer profiles has that. We have, like I said, these locations of providers and people like that. So a little bit more detail that you're able to kind of overlay onto the map. Yeah. And then finally, hotspots. This is similar. Again, you select your geographic level, select your variable or your category of variable, and then which variable you want to map. So this is just all cancer incidents. Again, you can add these locations here. Hit calculate hotspots, and it'll show you. So this is Montgomery, Lowndes, Butler, Dallas, Wilcox, and Crenshaw County, again, Black Belt counties. I don't think Montgomery's in Black Belt, but Dallas and Wilcox definitely are.
Do you mind hitting, did I see brain cancer as a general
Yep.
category?
Yeah.
Do you mind hitting that, please?
So some of the data have to be suppressed. There's not a ton of brain cancer in Alabama, but Clark County and Covington County seems to be maybe a little bit of a cool spot in Tuscaloosa County.
I asked John Waterbourne this question when he did his seminar a couple of weeks ago. There was a recent frontline piece on the carpet industry in North Georgia and cancer incidents in that area, and then they actually started moving into Alabama, the Coosa River watershed. And I'm wondering if you explored any of that.
I haven't. I did see something on Facebook that somebody sent me, though. There's some guy that lives, like, I don't know, in Escambia County or something, that, you know, kind of raised the red flag and talked to ADPH, or tried to talk to ADPH about brain cancer in Escambia County because of some kind of, I can't remember what it was specifically off the top of my head, some kind of environmental thing. And they kind of, you know, he was saying that it was a cancer cluster. Those are extremely hard to prove. You're probably never going to prove them, I mean, unless it's like really significant. But you know, I'm not saying it's not a factor. It's just, I don't know, ADPH might be like meh about it. But, you know, I definitely think, you know, unfortunately you got to wait on people to get cancer before you can really identify if it's a problem. But it might be something for us to keep a watch on. And I don't know, we could add rivers. We could add rivers too, I'm sure. Because you have the Tennessee coming down through here. You've got like the Coosa over in here, Cahaba over in here. So, you know, we probably could add that too. And again, that's why I want to get this out, is because I think everybody's going to have different ideas of things that we can add to make this Alabama specific, you know, as we go along. The other one,
I
yeah.
have a suggestion.
Yeah.
I'm looking at John Bassler back here. John did a wonderful paper on looking at the location of Dollar General stores.
Oh, yeah.
and as potential sites for COVID
Yeah.
vaccine.
Yeah.
Because there are a lot more Dollar General stores than there are pharmacies in rural areas. So if John is willing to give you the location.
There's a Dollar General on every block.
Yeah.
Yeah.
There's even a recently founded a very large database that gets updated every month or so that has locations data for everything from law offices to Dollar Generals to pharmacies to and things like that. Especially for some of these county programs, being able to include some of those locations and even overlay, you know, the large like interstates, highways, and things like that, because you know people, especially in Alabama, are familiar with like how the interstate bends and things like that. It's not always clear to people outside of the state, and we this is as much as we are the Birmingham, Alabama, essentially the national center that gets a lot of attention from you know other states or countries. There's a lot of interesting things you can do with this, and while I have your attention, that I'm working on something like this for HIV.
Yeah.
It's specifically Birmingham itself, because in addition to all these wonderful things that are included in this, Birmingham and its history of racial segregation and racial violence are also big factors in where people live, the factors that affect their health and things like that. And one of the biggest challenges I have in my current setup is getting it to function quickly. And that's what's really great about this is how quickly it can update how much data is here. It's really something because having it is one challenge, using it is the next challenge. And this covers a lot of those things already. Is this hosted at UAB? Or
Yes.
Is it hosted, so it's hosted at UAB?
So, well, and it's complicated. So they have Cancer in Focus Kentucky, right? And so that's their catchment area. So they've got the entire state of Kentucky working for them. Then they have cancerinfocus.org, which houses all of the data for every single center's catchment area. And that's where it's trying to, the R code is pulling from that website. That's what HSIS or IT, both of them, have blocked. So when I'm trying to pull that zip folder off of that website in the background, it's like, nope. And so that's one side of having to figure that out. But so, I mean, it's housed here. I built the code here. The Cancer Center web team had to actually deploy this to the internet using Posit Connect. So we have a Posit Connect license that O'Neill pays for.
That is what I was curious about.
Yeah.
Because the Posit Connect license is very expensive.
Well, Barry Sleckman was like, whatever.
It's supposed to the number of
Like gigabytes or whatever. Yeah.
you can do.
Yeah.
One of their upper level products also include options to make it restricted, so it can be a password, or that it's something that if you were to use this within the investigative community, you can protect it in some way if it does have some identifiable
Right.
information that's specific to a study.
Yeah.
Because that's one of the things I think about this kind of stuff is one, there's really two groups that could be valuable to, and that's us folks in this room and then the public in general. Right? So my question for that is how can we get this into the hands of doctors at these different hospitals, even patients, to have a better understanding of what's going on in their community. Because it's as much as it is on us to inform the public, being able to teach them to fish.
Yeah, so that's something I'm really passionate about, is educating people on where they are. And because that's the people that can advocate for those neighborhoods are the people that live in them. And I see I don't know if y'all seen the whole thing going on in Bessemer with the data center and how the residents in Bessemer do not want this data center. The city council is pushing it because of the money. And I'm like, if the city council, who's supposed to represent the people who are living in Bessemer and supposedly live in Bessemer themselves, are just they're not listening, how do we even help them if I don't, it drives me crazy because I'm like, if you're not going to listen to your citizens, what are you doing? Why are you elected? But, that gets into a broader political discussion. But, this has been running for since August or so, and I've done my best to educate people at the Cancer Center about it, and so has Dr. Nolan, who's the Associate Director for COE. Our office also has a network of people who live throughout the state that are community health workers, and then they manage 300 community health advisors throughout the state. Now, they're mostly in some of these black belt counties, and so we're trying to get the education out there for them. I think there's a little bit of a barrier with understanding what this is and why they might be interested in it. And I try to explain it as plain language. I don't even get into census tract, because they don't know what that is. They don't know what that means. They don't care. They probably are just interested in their county. And I mean, even the county information. If you live in Clark County, you're going to want to know that, right? And so, I would love to be able to disseminate this more broadly to more rural hospitals. I've got a study ongoing that I'm trying to recruit rural providers and rural healthcare administrators, and I am struggling. So if anybody knows anybody, and we can set up, Zooms or webinars or whatever to disseminate this, I would love to do that. The other thing that I wanted to show you is you can add custom data to this. Now, there's a caveat. So if you have a map layer that you want to add, you can add it here like if you've got like the geo IDs and the longitude, latitude, all that stuff, you can add it here. Whoops. So, it comes from your computer and you can add it. The problem is it's only going to stay in there while you're in your session. It's not going to be in there permanently for everybody to see. But my thought, especially since I work in a department that does a lot of cardiovascular disease, is, in Alabama, like we could have Cancer in Focus Alabama. We could leave it Cancer in Focus if it's on the O'Neill website, because that's what O'Neill's focused on. But we could also do Chronic Disease in Focus Alabama. And we could add HIV, and we could add cardiovascular disease. Now, I think that would require some collaboration with Todd, because he wrote the code, and I'm not going to sit there and try and break it. Because I would, because it's extremely like sophisticated R coding, and I would say I can code in R, but like not to that level. So I think there's a lot of opportunities for us to build something here that's very specific to UAB and to Alabama. I think the Cancer Center would want to leave Cancer in Focus, specifically cancer. But I mean, it would be an interesting collaboration if we could collaborate with Kentucky and us and, whoever else wanted to get involved and make a chronic disease in focus study. The thing is, with cancer incidence and mortality, it's a reportable condition. There's registries, so we know what the incidence and mortality is in it for cancer. I don't know about HIV. I know cardiovascular disease, you're probably not going to have a really good estimate of incidence and mortality, right, Dr. Lewis? Probably not, right? Same thing for like Alzheimer's, dementia, you're not going to have a good estimate for that. But there are some estimates out there that you could still just kind of, look at and put on a map and just see where they are, with the caveat of, knowing where the data come from, knowing how they were collected and everything. So that's the epidemiology part of this talk, right? But, the other thing I'll say, if you go up here to data sources, it'll tell you where all of these data come from. So you're not sitting there questioning, you can look further into them. They're all publicly available data sources. So you can go to the website, you can download the individual files yourself if you want to. You can also, let me go back up here. I think there's a way to download download data. So you can download the entire Alabama data that we have onto your computer and play with it in Excel or R or SAS or whatever you want to. Again, we're going to update this hopefully one day when IT figures it out. And you'll notice that it is copywritten by University of Kentucky, but they are chill with us. We have the license for UAB. They are chill with us adding whatever we want to make it Alabama specific. And so in my mind, why not try and add some chronic disease indicators and where parks are and Dollar Generals even, because we did a survey across the entire state of the needs of Alabamians when it comes to cancer care. Do you think we didn't recruit at a Dollar General? Yeah, we did. Dollar General, McDonald's, Walmart, Ace Hardware in Aniana. The Blount County Sheriff, Mark Boone, told me no, he didn't want to do my survey. He walked in with his little cowboy hat and said no. So, it's been a fun time. But, we were using all of those places that, people just kind of hang out. Because there's just not like a central place in those counties and those areas to recruit. And so, having a dollar. And you could think about this as like offering cancer screening if you had a mobile unit. Where could you go to get people cancer screening? Dollar General.
Yeah, the study that Earl was talking about essentially looked at the number of sort of traditional commercial vaccine providers that the county offered and the number of Dollar Generals that exist there, and basically found that the higher that ratio, when there's more Dollar Generals than vaccine providers, lower COVID-19 vaccination rates.
Mm-hmm.
So it's at the counties that you think it would be. But it wasn't like to prove, hey, like the more Dollar Generals you have, the less vaccinations you have, or just to kind of show that, hey, like this is a resource that can be tapped into.
Mhm.
And, you know, I love hard work, I could watch it all day. I would love to volunteer you for, like presenting examples of using this, because I
Mhm.
think that, you know, it's one of the challenges I have when, you know, shiny apps I make, is that you make them, and then you
Don't use
you
them.
like them, but you don't know how to use them.
Oh yeah.
So demonstration is great, but like something like an example of
Mhm.
like, even from like a student perspective.
Yeah.
Okay, I want to use a project. Like use this data for a project. Here's how I can pull the visualizations that could be incorporated in my report. Here's how I pull the data. This is like the kind of questions I can ask as far as like what it is appropriate to answer for this kind of data. There's a lot of utility of it.
Mhm.
It's exceptional tool that
Yeah.
can be used everywhere from students, faculty, to the providers
Yeah.
outside the system as
Well, I'm not going to volunteer her, but Lauren Roberts, who's the CEO and founder of Forge Breast Cancer Survivor Center, heavily uses this. And so she would be a good one to kind of explain how they've used it to target their efforts. Like I said, they do a lot of different things for women who are survivors of breast cancer, from the date of diagnosis all the way to the end of life. So they've used it to provide women with wigs and like financial assistance for treatment, or if they just need some dadgum groceries because they can't afford them because they're in cancer treatment. So they've used it extensively, and they keep asking me about Mississippi because they work in Mississippi too, and I'm like, that's UMMC. I mean, I'm happy to help them get in touch with Todd and figure out how to work around all of the nuances and stuff, but I can't develop it here because we don't catch Mississippi technically, even though we do, but we don't. So anyway, yes, short answer. Would love to disseminate this further. Would love to figure out how to let people use it, because we're also tracking the site usage and stuff for the Cancer Center support grant that's going in May. So anyway, but that's everything. If you have any questions, feel free to email me. Happy to answer them. Feel free to go on, play with it, just look at stuff. I just sit and play with it sometimes because I'm just like, this is interesting. And, I'm from Alabama, so I'm like looking at Lauderdale County where I'm from and looking at where my grandparents are from. I thought there'd be hotspot for pancreatic cancer where my grandparents are from, because literally if you go down the road that my grandparents lived on, at least one person in every house had pancreatic cancer. But they also all smoke, so, So anyway, I've played with it a lot. I think it's kind of fun to play with, kind of interesting, and it might spark some research questions or some internship questions or something. But thanks.